topic for my discussion today was imaging of the wrist. So imaging of the wrist is, basically wrist is made up of 15 different kinds of bones. With 15 bones there are joints in between them and a lot of ligaments supporting the joints as well. So it's like peeping inside the Pandora's box, not exactly opening the Pandora's box, but peeping the Pandora's box. So like keeping in lieu with the theme of our conference, basic orthopedics and novel evolutions, let's start with my talk. So yeah, in order to start with, if you want to have a imaging modality for a wrist, the basic and foremost important is to have a good clinical examination. And the good clinical examination can only be done when you have a good knowledge about the surface anatomy, which is very important. Later, we all know what are the imaging modalities of the wrist are. The radiograph, the CT scan, the MRI, contrast and ultrasound. But let us see which one is the best and how we can use all these imaging modalities for the best possible, for which the patient can also benefit from it. Now, since the inception, since when the X-rays was been evolved, on the 22nd December 1895 by William Conrad Röntgen, the first test subject of his was his own wife, which was Anna Bertha, for which the first X-ray which was taken off was his own wife's hand with a wedding ring in hand. Since then, which took 20 minutes at that time to have an X-ray, now it has been evolved to just to have less than 2 seconds for it. So radiograph is best and the foremost one investigation for the wrist which we should start with. Then the proper PA view. Let us see how the most important part is the position of the hand while taking the PA view. Now this is most important, and let us see how a good PA view looks like. Let's start with the basic orthopedic part to begin with. So let's see what are the things we should look for in a good PA view. First of all, there should not be any rotation between the radius and the ulna. The ulnar styloid should be arising from the most ulnarmost border of the ulna as well. Then again, the ECU groove. Now what is the ECU groove? The good PA view will definitely give you a good ECU groove. This is a groove longitudinal line extending proximally from the base of the ulnar styloid, located radial to the fovea. The ulnar variance, which is most commonly seen during the distal radius fracture which we measure, it depends upon the position of the elbow. So many times even a technician or even most of the orthopedic surgeons as well, they just take having a wrist with keeping the hand adducted and in front position. But ideally the hand has to be shoulders abducted, elbow flexed to 90 degrees and palm facing downwards. So if the elbow goes underneath the shoulder, the height of this ECU groove overlaps the ulnar styloid, and with more adduction of the elbow towards the patients, it will make the ulna become more positive, and that's why it will give a very sense of false positive ulnar variance. Now let us see the relations of the carpal. This one half of the lunate should be in contact with the articular surface in a good true PA view. The articular surfaces of the carpal bone should be parallel and the joint spaces should be 2 to 3 millimeters, not more than that. Then there are different relationships between the arcs called as a gillular arc. These are like curvilinear, somewhat almost parallel to each other. There are 3 lines of it. One is along the capitate and the hamate, the proximal row of the capitate and the hamate. Then the distal part of the distalmost aspect of the proximal row, which belongs to scaphoid, the lunate and the triquetrum. And then the third line is along the proximal aspect of the proximal carpal row. Now let us come to the lateral view. The lateral view, again the position has to be very very definite and particular. The lateral view mostly is seen with the collinear relationship between the capitate, the lunate and the radius. Now this relationship has been linked to what is called the thigh rose apple fruit, that sits in the cup made up of the lunate, which on the top sits on the saucer of the radial surface. Now another way how to know whether it's a true PA view or true lateral view is it's called by the line of the sight. Just understand it's a very simple thing with which you can just identify whether the wrist is a great lateral view or not. So the position of the scaphoid, pisiform and the capitate, it tells whether the wrist was in pronation or supination while taking the X-ray. So the palmar margins of the pisiform is projected midway between the palmar margins of the distal pole of the scaphoid and the head of the capitate. So this is the pisiform which is right in between of them. If this is there, then that is a true lateral view, and in that case only you can gauge whether there is a DRU, just subluxation or dislocation. Now, let us start with some of the dynamic views of the wrist. So, this is the PA with ulnar flexion view. Now, scaphoid is the most humble bone of all the 15 bones in the wrist. It is always in a flex attitude saying that thank you very much. So, in order to identify the entire full profile of the scaphoid, it is necessary to have a good PA with ulnar deviation view. Now, what happens in an ulnar deviation is the scaphoid, rotates dorsally and ulnarward, giving the entire profile of the scaphoid. Now, pronation oblique view, it is done by taking the oblique view and keeping the 45 degrees angulation. It is mainly done to evaluate the radial side of the wrist, the first metacarpal base, the trapezium, the scaphotrapezium trapezoid joint, and the tuberosity of the scaphoid. The second is the supination oblique view, which is also called as Nogart's view, and you are in a good hands with SL view, in which it is done mostly for the pisiform bone fractures. Clenched fist views, again it is done to demonstrate any diastasis in regarding to the scaphoid unit. Again, while doing this, you should have a sight of the contralateral site as well. Then also compare with the capital unit as well. Then the carpal tunnel view. Now, this view is mostly used for all the detection of the palmar surfaces of all the carpal bones. So, like the trapezium, the trapezoid, the capitate, the hook of the hamate, and the pisiform bone. Now, the most common fracture and the most neglected and the most misdiagnosed is the perilunate and the lunate dislocation. Now, let us see how one can diagnose a lunate. It's a very simple thing to diagnose. So, let's compare the PA view normal and let's compare that of the lunate dislocation or perilunate dislocation. You see that the lunate is basically, it's called a lunate because it's the shape of the moon. But actually in a true PA view, the lunate just looks like a trapezoid shaped bone. Now, if this lunate appears like a triangular, it is most commonly there is some wrong with it. Along with that, you should trace the Gilula's arc as well. So this is called as a piece of pie sign. Also in the lateral view,
Dr. Kamble, wind up please.
I guess the other talkers, they took my time as well. So the difference between the lunate dislocation and the articulation is that the lunate, in lunate dislocation, the radial articular surface is disrupted and displacing the lunate volar verts, creating the spilled teacup sign. And again, the main difference between the lunate and the perilunate is the lunate's articulation with the radial surface. If it is intact with the capitate being dislocated dorsally, it is basically called as a perilunate dislocation. And when the lunate comes out of the articular surface of the radius, it is completely called a lunate dislocation. Understanding the DC and VC deformity, I know it is very dangerous when we are having a PG, but just remember three friends, like two extremes, one scaphoid and one triquetrum. Scaphoid has a tendency to flex and the triquetrum has a tendency to extend. So, and there is an intercalated fragment in between, which is a best friend and it holds both the bone together. Now, supposing there is an injury to the scapholunate ligament, so then what will happen? The lunate will go along with the capitate and will try to extend, which is called as a DC deformity. And the other way around, if there is a problem with the, it called as a VC deformity. Now again, the radius fractures, again another topic will take another 10 minutes of time, but if there is a comminuted fracture only, then I'll ask for a CT scan, or if for a soft tissue injury associated with it, can ask for a MRI as well. In distal radius fracture, which I want to stress upon, is always try to have a stress view or a tractional view before committing upon this. This is the best possible thing which you can achieve rather than having a CT scan, because once you relocate or once you reduce a given traction, many a times.
10 seconds, please.
Okay, sorry. So like the take home message. Although CT and MRI are superior in certain aspects other than conventional radiograph, the basic method of examination still remains the plain radiography, and the radiography proper position and exposure can provide an accurate information for the wrist pathology. Use of these tools effectively and in close cooperation with the clinician and radiologist will have a good possible protocol for the patient. And too many kinds of imaging techniques are available and evaluation of wrist conditions, but because the history of the imaging and the wrist begins with the plain radiograph, I think that any kind of imaging examination on the hand and wrist should always begin with the plain radiograph. And these skills, if mastered, will have us to excel in our career. Thank you so much.
Thank you, Dr. Kamble.